طيب عشان ما أطلع عليكم خلينا نبلش لو سمحتوا بدور. First lecture will be about pediatric urinary tract infections. So in general, the urinary tract should be sterile at all times. Sterile means there shouldn't be any bacterial overgrowth in the urinary tract in the normal situation. Urinary tract infection can be caused by multiple organisms, most commonly, if symptomatic, to be caused by bacterial etiologies. However, it can sometimes be caused by viral etiologies and fungal, especially in the immunocompromised and those on immunosuppressive therapies. Okay, we divide the urinary tract into upper and lower urinary tract. The problem is that there's no actual valves between the upper and lower urinary tract, so urine can move freely between both. So the presence of any bacterial overgrowth in any part can disseminate to the other. When we say lower urinary tract infection, we mean cystitis. So the infection is confined or localized to the urinary bladder, and this will most of the time cause localized symptoms. So rarely any systemic symptoms. So you will not find cystitis, for example, with high-grade fever or significant leukocytosis, okay? However, pyelonephritis is what we always fear of. This is the upper urinary tract infection that comes with systemic signs and symptoms and carries a risk to develop urosepsis or dissemination into the bloodstream. The term asymptomatic bacteriuria is when we do a urine culture for any reason. We find bacterial overgrowth. However, the baby or the kid is totally asymptomatic. Whether to treat or not to treat, this depends on individually on the patient and the overall condition of the patient, and to why we did the urinary studies anyway. So all in all, about 3% of girls and 1% of all boys before puberty has had at least one urinary tract infection. Before the first or during the first year of life, it's more commonly seen in boys, and this is related mainly to anatomical problems and urinary tract obstruction and anatomical complications. So we tend to see these anomalies, obstructive anomalies, in boys more than females. However, beyond the age of 1 year, we tend to see UTI more commonly in females, and this is due to many factors like the shortness of the female urethra, the contamination with the perineum, microorganisms, hormonal changes as well, and the way of the area hygiene differs between male and female. Okay. Boys who are uncircumcised, they have 10 times more risk to develop UTI. So any uncircumcised boy with non-specific symptoms, we have to rule out UTI, even if they are afebrile, even if they don't have the typical urinary symptoms. Okay. Regarding the etiology of urinary tract infection, the most common is gram-negatives, and amongst gram-negative bacteria, E. coli is the most common cause of UTI because it's an inhabitant in the region, in the area. So rectal and perineal colonization with E. coli is normal, and this will give a chance for E. coli to disseminate and cause urinary tract infection. Other gram-negative bacteria like Proteus and Enterococcus, Klebsiella, literature say that Proteus UTI is more common in males than females. They justify that or explain that by saying that Proteus tend to colonize and overgrow in prostates usually. So the prostate acts like a nidus for Proteus in most of the cases. Pseudomonas aeruginosa is very rare to find in otherwise healthy individuals, unless they're immunocompromised or there's indwelling urinary tract catheter. Gram-positive like Staphylococcus saprophyticus, so not Staph aureus or epidermicus, Staphylococcus saprophyticus. Viral etiologies are much less common than bacterial. Amongst all viruses, adenovirus tends to cause significant cystitis and inflammation and emerging cystitis in individuals. Fungal causes, again, very rare unless the patient is immune compromised or there's a foreign body, prolonged use of antibiotics and prolonged use of steroids. Okay, so the source of the infection is either descending from blood, so blood, and then tend to localize into the urinary tract, or ascending, which is the most common cause or etiology of UTI. Okay, what are the common risk factors? So all in all, as we say, in all age groups, female, being a female carries a higher risk, and we know that this risk is significant before puberty and after puberty and during the childbearing age, due to many factors. Uncircumcised males is a risk factor as well. Toilet training, so we tend to see UTI cluster in like specific ages, specifically around toilet training, where kids tend to start depending on themselves to go to the toilet and clean the area. Any source or any cause of urinary stasis, urinary outflow obstruction will increase the risk to develop UTI. So constipation and somehow causes stasis, relative stasis, and increase the risk of UTI. Any external compression or obstruction, like in pregnancy, tumors, stone, etc., can increase the risk of UTI. We know that renal anomalies carries a very high risk to develop UTI, specifically recurrent types of UTI that eventually can cause scarring and end-stage renal disease. Anatomical problems like what we see in spina bifida. Those with myelomeningocele, they have like abnormal or inadequate innervation to their bladder or abnormal innervation to their bladder. This will lead to inappropriate signaling to when they need to go to the toilet, and this can cause incontinence, which carries a risk to develop as well UTI. Symptoms of UTI, usually they depend on the age and the etiology. So those below the age of 2 years, including the neonatal period, they present with non-specific symptoms. So symptoms that are not necessarily related to the urinary tract itself. So they might present with colicky abdominal pain, irritability, they might look unconsolable, fever, mild, moderate, or high-grade fever as well. Diarrhea, vomiting sometimes is the presenting symptoms of UTI in this age group. However, beyond the age of 2 years, they will start to show specific symptoms of urinary tract infection like urgency, frequency, dribbling, etc. Why do we fear complications of UTI, and why we always need to tackle down any urinary tract infection and treat promptly and as soon as possible? Because of the complication that subsequently can happen. One of the most feared complications of UTI is the development of renal scarring, which is due to continuous chronic inflammation in the renal parenchyma. Okay. Other complications include renal abscess formation and others like sepsis. If it started localized urinary tract, it can cause later on ureasepsis. Long-term complications of recurrent pyelonephritis are hypertension and end-stage renal disease. So how do we diagnose? So we always say that in most of pediatric age group illnesses, 70% of the diagnosis is reached to by history and proper physical examination. So you have to have proper detailed history and physical exam. Regarding lab investigation, either we do the microscopic urine analysis or the rapid dipstick that can be done in any clinic setting, and it takes less than a few minutes for the result to come out. You need to confirm the microorganism and sensitivity using urine culture. Sometimes we need to do imaging in specific situations, and there's specific indications to do that. Physical exam, what to look for examining a kid that you suspect might have urinary tract infection. Abdominal exam might show either profuse, diffuse tenderness or sometimes localized suprapubic tenderness. Costophrenic angle, tenderness upon examination. This indicates upper urinary tract infection all the time. Now, we need to do lower limb examination. Well, this is as part of your assessment of the neurological situation of the kid, whether the kid has any risk for to have like what we call a neurogenic bladder, and this is what we see in kids with myelomeningocele, for example. So you need to have a good examination for the lower limbs in terms of tone, power, and reflexes. You have to check vitals, including blood pressure, growth parameters, because below the age of 2 years, one of the common presentations of UTI is failure to thrive, okay? So keep that in mind. Any kid with failure to thrive, unexplained with dietary history, unexplained with malabsorptive disorders, you have to rule out UTI as a cause of failure to thrive. Back or for sacral, temple, or hair, tuft of hair, this is to rule out myelomeningocele. And lower limbs edema, this is what we see in chronic renal involvement and chronic renal disease. Obtaining urine samples, there are multiple ways to obtain urine samples. We can go through a midstream, what we call it midstream clean catch, in kids who are toilet trained above 6 years of age. Other ways to do urine collection is using urine bags, and we don't prefer this collection because it would be totally and significantly colonized with the normal microflora in the area. Suprapubic aspiration for those young, like neonates, less than 2 years of age, untoilet trained, we do suprapubic aspiration. But it's considered a very invasive method to do. It's actually, you will use a syringe, a needle, and you will go directly towards the bladder and aspirate. One of the complications is hemorrhage, for example. Sometimes you can actually perforate and obtain a stool sample instead, and we saw that a lot previously. Okay, so urine analysis is when we analyze components of the urine without doing culturing for the urine sample, okay? So we basically, with macroscopic urine analysis or dipstick urine analysis, we look for the presence of cells in macroscopic evaluation. We look for the presence for nitrites, and we tend to measure the urine pH, glucose component, protein component, and the presence of leukocyte esterase that we see in urinary tract infection. Dipstick is a qualitative test rather than quantitative, so it tells me whether there's nitrite, whether there's leukocyte esterase, but it doesn't tell me about the quantity of presence, the quantitative presence of cells like RBCs and YBCs. Here comes the role of microscopic evaluation of urine samples, looking for other types of cells like tubular cells and epithelial cells. So the presence of tubular and epithelial cells represent renal tubular and renal tubular inflammation and renal injury, whether it's acute or chronic injury. Okay, how should urine normally look? It should be clear, yellow in color, not foggy or cloudy, not frothy. If we look at it, you shouldn't see the froth on top of the urine sample. The normal pH should be anything between 4.5 and 8, always alkalinized urine. This is a sign of infection. The normal specific gravity is between 1.005 to 1.025, and this sometimes we depend on this as well to look for signs of dehydration. Glucose levels, normal glucose levels, anything equals or less than 130 milligram per deciliter. So nitrite and leukocyte esterase, normally you shouldn't find them in a normal healthy urine sample. So nitrite, leukocyte esterase always indicates an underlying infection. RBCs, we accept up to 3 cells per high power field. And for white cell count, we accept up to 5 cells per high power field as well. Cast up to 5 as well. So this is to show you how we do dipstick. So it's done in clinic settings, and it's very quick. Okay. Microscopic evaluation, as I said, we look as well for the presence of bacterial colonies per high power field, but it doesn't tell me anything about the identity of the colonies or the bacteria observed. Okay. So a common question, can we depend on urine analysis without culture? So if you obtain just a little bit of like urine, you send it to microbiology and they've done urine analysis only. So is it enough do we say, okay, I can depend on this sample and we don't need to run another sample for culture? What do you think? Well, I'm not, regardless of the method of collection. So you've collected any sample with a sterile method, let's say suprapubic aspiration, and you've run urine analysis only. Can we say that urine analysis is enough to identify UTI without the need of culturing? Well, there's one condition to that. So if you test with your analysis nitrite, if you test for the presence of leukocyte esterase and the microscopic presence of bacteria, if you've done all of the three, you can sometimes, if it's negative, it has a fairly good negative predictive value. So you can say that, okay? However, this can't be used in pigs all the time. You need to have to culture any sample that you obtain. So the gold standard to diagnose UTI is to run a urine culture and sensitivity as well. The way we collect the sample, okay, will guide me to diagnose whether this is considered a UTI or not. Globally, the numbers at which we say this is a significant cause depend mainly on the route or the way of urine collection. So if we do a clean catch, midstream clean catch, so there are conditions, it has to be a clean catch. So we usually give instructions that the area should be thoroughly clean before we collect the sample, and you have to ditch away the initial urine and then you take the midstream part of the urine to culture. So if it's a clean catch, midstream, you consider this as a positive culture if it's anything above 100,000 colonies per milliliter, and this is if the patient is asymptomatic, okay? However, if the patient is symptomatic, so the patient is showing typical signs and symptoms of UTI, it's anything between 10,000 and 100,000 colonies per milliliter. For catheterization, so catheter method, it's almost the same. So symptomatic versus asymptomatic. And asymptomatic, anything above 100,000. If asymptomatic, more than 10,000 is enough to diagnose UTI. As I said, we don't depend on bag collection because usually it's significantly contaminated. So suprapubic aspiration. Suprapubic aspiration, as I said, it's used for those who are not toilet trained neonates and less than 2 years of age, because this way we do it, the suprapubic, we do it under sterile technique. Yeah, we clean the area, we make sure that there's no microorganism contamination over the skin, and then we aspirate urine using a sterile syringe and needle. Anything above colony is considered positive for suprapubic aspiration, regardless of the symptomatology of the patient. Imaging. So the role of imaging studies done in kids with UTI is basically to identify any risk factors to develop UTI, like any anatomical problems, obstruction, anatomical variation like double ureter, horseshoe kidney, ectopic kidney tissue, etc. Or to look for complicated UTI when the patient is not responding to the proper antibiotic used to treat UTI. Okay, so it's estimated that those who present with febrile, recurrent febrile UTI, they do have 50% of them, up to 50% anatomical problems, making them at risk to develop recurrent pyrogenic urinary tract infection. Imaging modalities, they vary from a simple ultrasound to a DEMS scan, and this is the reason to why we choose one over another depends individually on the situation that you're dealing with. So for ultrasound, this is for non-toilet trained kids who develop UTI to exclude any structural anatomical anomalies. Okay, VCUG or voiding cystoarthrogram. So we give contrast with this study, and we look for the stream of the contrast with urine. We use this to look for hydronephrosis and specific scarring or other possible cause of obstruction. DIMSA scan, technetium scan, when we know there might be scarring and kidney injury. So for someone with, so we've done VCUG, and the patient has reflux of grade, for example, 3 or 4, and the patient has a background of recurrent UTI, then I need to do DIMSA scan to rule out scarring. So can you see the difference of the uptake between the right kidney and the left kidney? Okay. Hydronephrosis, meaning there's dilatation in the pelvic calyceal system, and this will make the patient or the kid liable for recurrent UTI and kidney injury due to sometimes outflow obstruction. Okay. The best modality to diagnose reflux is to do VUR. It gives you an idea about the anatomy of the urinary tract and the degree of reflux. Okay, so when do we use the cycle? When do we use the VCUG exam? Okay, so we use it when, so previously they used to do this, the VCUG exam after the initial or after the first UTI, so it's no longer the case. You do it if the patient develops recurrent UTI, this is number 1. If the patient has undergone ultrasound that showed hydronephrosis or dilatation in the pelvic calyceal system, then okay, you do the VCUG. If there's any evidence of scarring on DIMSA scan, you can follow up with VCUG. So be aware that VCUG is not something that you do once. So if the patient has, for example, reflux, you have to do this on a regular basis or in specific intervals to make sure that the reflux is not increasing. For example, the dilatation is not increasing and things are not getting worse. If you do initial VCUG and find it suggests significant high-grade VR or obstruction, you need, as I said, you have to follow up the patient. The patient has to be on prophylactic antibiotic, has to be strictly followed up by a nephrologist. When there's atypical infection, we need to rule out any anatomical cause for the atypical infection. So we do VCUG or MCUG as it was called previously. Any family history of reflux and UTI needs to be, you need to do VCUG. So this shows the grades of VUR, 1, 2, 3, 4, 5. 1, 2, usually they're called mild reflux. 3 and above, they carry significant risk to develop kidney scarring and end-stage renal disease eventually. Okay, UTI treatment. So we don't wait for the culture to come out, so we do the analysis or the dipstick. If they show signs or if there's index of suspicion that the patient has UTI, you need to start empirical treatment before the culture comes out, okay? And then when the culture comes out, the sensitivity comes out, you adjust according to the sensitivity that you obtain. When the culture is negative, you stop the antibiotic, even if you haven't finished the full course of treatment as per the international guidance. What supportive treatment can you provide the patient with? So with UTI, kids are febrile, sometimes irritable and pain, so you have to provide with a good analgesia. If you start proper empirical antibiotic and then you adjust according to the culture, but the kid is still spiking fevers, not showing any signs of improvement, so you need to repeat the analysis and culture and do imaging to rule out any complications like abscess formation. If there's an abscess, you have to consult surgery for abscess drainage. Okay, so neonates with UTI, usually we tend to treat for more extended duration, so 10 to 14 days at least, because of the highest risk to develop bacteremia following UTI. For cystitis, well, nowadays it's not required to treat for 7 to 10 days. Nowadays they say 3 to 5 days is more than enough to treat cystitis, specifically if the kid is well looking and there's no significant symptoms like hematuria or pyuria or significant pus in urine. Amoxicillin. So amoxicillin, although theoretically speaking, it covers, it has good gram-positive coverage and some coverage for gram-negatives like non-extended spectrum beta-lactamase producing bacteria. Theoretically speaking, it should work for UTI because amoxicillin, we find it in good urine concentration. So the urinary concentration of amoxicillin is satisfactory. However, we don't use it. It's not amongst the first choices to treat UTI because nowadays there's high incidence of bacterial resistance to amoxicillin, which is considered an aminopenicillin. Okay? Bactrim is a good drug of choice to treat UTI. It has good urinary concentration. It covers most of the etiologies of UTI. Third generation Sparasporin, either IV or oral, is another option. However, they are somehow expensive. For ceftriaxone, for example, the patient needs to be inpatient. For cefixime, as we said, it's expensive in comparison to other options of antibiotic, and it is broader in spectrum. Okay, so we have to be cautious choosing cefixime when we treat infections in general, because it has broad gram-negative and gram-positive coverage. Okay, so this is how the duration of treatment differs between different age groups. As I said, in neonates, you have to treat anything between 10 and 14 days. Beyond the natal period, the choice between IV and oral depends on the overall condition of the patient. So if the patient is well looking, can maintain oral antibiotics, doesn't look ill, non-toxic, there's no hypertension, vital signs are stable, you can discharge and treat as outpatient. However, if any of the flags is present, you have to admit and use broad spectrum IV antibiotic like ceftriaxone. The duration of treatment for lower, as I said, nowadays they consider 3 to 5 days as more than enough. For upper urinary tract infection, 7 days is enough. Unless we're talking about a resistant microorganism like ESBL positive microorganisms. So when do we admit patients to treat UTI? Anyone less than 2 months of age, someone who's looking very toxic, okay? Now, less than 1 month, and so less than 2 months, if febrile, you can consider outpatient treatment. Less than 2 months, febrile, you admit. Less than 1 month, regardless of fever, you admit and treat as inpatient. Or if the patient is unresponsive to oral treatment. If the patient is immune compromised, you have to admit. If the patient is showing any signs of systemic toxicity or red flags, you have to admit. Okay, how to prevent UTI? Good hygiene, specifically in the newly toilet-trained kids. You have to educate on how to clean the area before using the toilet, hand hygiene, hand washing, specifically in schools. Well, prophylactic antibiotics, we don't usually prescribe prophylactic antibiotics unless the patient has a previous history of recurrent UTI, the patient has a risk like someone with VUR, the patient is at risk to develop renal scarring, someone who's born with single kidney. So beyond the first UTI, if it's recurrent, you tend to start them on prophylactic antibiotic. Cranberry juice doesn't prevent UTI significantly. However, they say it might decrease the likelihood to develop UTI, specifically in females. هلا محاضرة الانتيبيوتكس شوي طويلة.